My name is Thomas Lee, and I am one of the maternal fetal medicine specialists at Northwest Perinatal Center. And today I'm going to be talking to you about contemporary management of second trimester sonographic aneuploidy markers. So just a little bit of historic background. The development and use of sonographic markers for aneuploidy really arose during an era prior to our current methods of aneuploidy screening, such as sequential screening and NIPT. At that time, women had very few choices beyond maternal age to assess their babies for potential aneuploidy, with age providing only detection rates of 20 to 30%. And so there was a need for additional non-invasive methods to improve detection rate, and so this is the role that these markers served. What hasn't changed since then is that when a sonographic aneuploidy marker is identified, that is an indication to perform a more detailed evaluation of the fetus, looking for other sonographic markers and/or structural abnormalities. I want to introduce a concept known as the likelihood ratio. So the likelihood ratio is really a statistical descriptor, much like, to a certain extent, odds ratio, which you may be more familiar with. But the likelihood ratio is a descriptor of the likelihood that a given finding, like an aneuploidy marker, would be expected in a fetus with a disorder like Down syndrome. So simplistically put, a likelihood ratio greater than 1 suggests a higher likelihood that the baby would have Downs, versus a likelihood ratio less than 1, a lower likelihood. Likelihood ratios can be used to adjust maternal age-related risk. And so it's important, though, to remember that the likelihood ratios that I'm going to present in the presentation are in relation to maternal age-related risk estimates, and these likelihood ratios should not be used to recalculate maternal risk after prior aneuploidy screening, such as sequential screening or NIPT. So don't use these. So I'm going to just go over a bunch of the sonographic markers that you may see on ultrasound reports, or we may call you about. And so just to give you a sense of what do these look like and what really is the relevance of these. So we're going to first start off with echogenic intracardiac focus, or EIF. There on the screen, you can see a 4-chamber view of the baby's heart, and an EIF is an echogenic area appearing within the heart with the sonographic brightness equivalent to that of nearby bone when you turn the harmonics off. This is pretty prevalent. You can see this in about 3 to 5% of all euploid fetuses and up to 21 to 28% of Downs fetuses. This carries with it a relatively modest likelihood ratio of 1.4 to 2.8. Fortunately, beyond the association with Down syndrome, an echogenic intracardiac focus has no other clinical implications, and really beyond that has no effect upon cardiac function. We then move on to pyelectasis. Pyelectasis is also something that we frequently see. On the image there, you can see a transverse view of the fetal kidneys, and we measure the renal pelvis in the transverse AP plane. Pyelectasis is defined as an AP diameter greater than or equal to 4 millimeters prior to 28 weeks. Of note, after 28 weeks, that cutoff rises to 7 millimeters, but at that point, the aneuploidy association no longer applies. You can see this in about 1 to 3% of euploid fetuses and 10 to 25% of Downs fetuses, but again, a very relatively modest likelihood ratio of 1.5 to 1.9. Importantly to remember is that pyelectasis also can be suggestive of urinary tract obstruction and will require additional follow-up that we'll talk about later. Another marker is a shortened femur length, and trust me, that is a femur that we're measuring there in the image. A shortened femur length is defined as a measured to expected ratio based upon the biparietal diameter of less than 0.91. There is a calculation that needs to be performed, so fortunately there are some online calculators that we use, which makes this easier to determine. When that ratio is less than 0.91, the likelihood ratio again is relatively modest, though, with shortened femur of 1.2 to 2.7. It's important to remember that whenever you do see a shortened femur, you also need to be thinking about other potential causes like fetal growth restriction and skeletal abnormalities. Similarly, the shortened humeral length, in the same vein, we calculate a measured to expected ratio, and shortened humerus length is when it's less than 0.89, and you can see the calculation there. This has a slightly higher likelihood ratio for Down syndrome of 2.5 to 7.5. And again, you need to be thinking about growth restriction and potentially other skeletal abnormalities, which emphasizes the need again for a more thorough survey of the fetus whenever you do see a sonographic marker. Echogenic bowel is also a sonographic marker. In the image here, you can see to the right is the fetal head, and this is a longitudinal view of the fetus. This is the fetal chest, fetal abdomen. You can see ribs here, and this is the bowel. The bowel is considered echogenic when it appears as bright as the nearby bone with the harmonics turned off and the gain turned down. We can see this in about 1 to 2% of euploid fetuses and 13 to 21% of babies with Down syndrome. Again, a higher likelihood ratio of 5.5 to 6.7, so a bit more significant. Other things that are within the differential diagnosis whenever we see echogenic bowel: fetal cystic fibrosis infection, CMV infection, and early signs potentially of a GI tract abnormality. Thickened nuchal fold. This is a transcerebellar view of the fetal head. Here you can see a measurement of the cerebellum. This is a measurement of the cisterna magna, and this is what we measure as the nuchal fold. We call it thickened when it's greater than or equal to 6 millimeters between 15 to 20 weeks gestation. Some authors suggest you can take that up to 22 weeks. It's reported to be seen in about 1% of euploid fetuses, perhaps less, but a much stronger prevalence within fetuses with Down syndrome, 40 to 50% prevalence, and a much higher likelihood ratio between 11 and 18.6. Really beyond the aneuploidy association, the nuchal fold doesn't have any additional significant associations. And then finally, well, not finally actually, absent nasal bone. This is the newest kid on the block. Absent, you can see here that this is the mid-sagittal plane of the facial profile, and usually there is a bright linear structure here which would represent the nasal bone, and obviously there isn't one there. And so when it is absent in the mid-sagittal plane, this can be seen in about 0.3 to 0.7% of euploid fetuses and 30 to 40% of trisomy 21 fetuses. This carries with it a significant likelihood ratio of 23, according to the literature. Mild ventriculomegaly. This is a section through the fetal head, and you can see here that we are measuring the lateral ventricles at the level of the atria. Ventriculomegaly, at least the mild form, is defined as a measurement between 10 and 15 millimeters. We can see this in 0.1 to 0.4% of euploid fetuses and 4 to 13% of trisomy 21 fetuses. The reported likelihood ratio associated with this and Down syndrome is 25. Whenever we do see this, again, other things we want to consider are potential etiologies such as CNS abnormalities and potentially fetal infections such as CMV, toxoplasmosis, syphilis, and more recently, Zika virus. And then finally, I want to touch on the choroid plexus cyst. This is very commonly seen. This is an echolucent structure within the choroid plexus. Typically, we look for it when it's sharply circumscribed margins. We can see this very commonly in 1 to 2% of euploid fetuses, However, up to 30 to 50% of trisomy 18 fetuses. So this has more of a trisomy 18 association rather than a trisomy 21. Beyond this, there are no other potential clinical associations. Of note, it's pretty rare to have a trisomy 18 fetus with just a isolated choroid plexus cyst. Because of the severity of trisomy 18, you're usually going to see other findings in those fetuses. I just wanted to put up, there are a whole slew of other potential markers that have been reported in the literature. And just for completeness sake, I wanted to list them here. But really going into these in greater detail is probably beyond the scope of this short talk. So what about kind of the contemporary management currently? Because we no longer rely solely on maternal age anymore. We do fortunately have at our fingertips other methods of non-invasive screening for aneuploidy. And relative to, if you remember, maternal age, which had a 20 to 30% detection rate for Down syndrome, now we have sequential screening, which has a reported 93% detection rate for Down syndrome, and cell-free DNA or NIPT, which has a 99% detection rate for Down syndrome. So really, what is the utility or the purpose of these markers anymore? And the reality is that, well, historically we have used these and we can't really ignore them or just throw them away. So how do we deal with this in the era of these other more sensitive screening modalities? So recently, the SMFM has published recommendations on really how to deal with this, and so important to kind of pass this information on. So let's take the clinical scenario of when you see a single sonographic marker for aneuploidy in isolation, and the patient has no prior aneuploidy screening, which is relatively common in our patient population. So one option is to adjust the risk based upon the presented likelihood ratios that I've reviewed. For example, a mom who is 33 years old will have an age-associated risk of 1 in 441. Let's say we see an echogenic focus and the likelihood ratio at worst case is 2.1 or 2.8 associated with that. We can recalculate for her what we think her new risk estimate for Down syndrome is, which would be 1 over 441 times 2.8 or 1 chance in 158. So that is kind of the first step, quick and dirty, that you can do. But additionally, you can offer and should speak to her about potentially performing either second trimester serum analyte screening or the quad screen, or performing an IPT. But what about the mom who has already had prior aneuploidy screening and that result was already considered low risk, and that includes both NIPT and sequential screening. So when you see a single sonographic marker in isolation, again, to reiterate, we don't use these likelihood ratios to recalculate her risk. For many of these, we can just consider this a normal variant, and such as an EIF or a choroid plexus cyst, and move on and reassure her that the likelihood of her baby having Down syndrome or trisomy 18 is relatively low. There are a number of other findings, as you can see here listed, pyelectasis, ventriculomegaly, and echogenic bowel, where, yes, there is follow-up that is required, but the association with aneuploidy can be minimized. Of note, additional diagnostic testing is not recommended in these situations. When you see more than one sonographic marker on ultrasound, the likelihood of aneuploidy is definitely higher. It really does depend upon which markers that you're seeing. And in these cases, we do recommend referral for genetic counseling to go over what these risks may be and the consideration for diagnostic testing. And then finally, as I said, there are some markers that do require additional follow-up. Just to go through a few of these, when we do see pyelectasis, Because of the association with urinary tract abnormalities, reevaluation at 32 to 34 weeks is recommended. For short humerus or femur, we want to evaluate the fetus for potential growth abnormalities or skeletal problems. Echogenic bowel, consider testing for other potential etiologies such as cystic fibrosis, CMV, and GI tract abnormalities. And then finally, with ventriculomegaly, we want to evaluate for other etiologies such as CNS abnormalities and fetal infection. So to summarize, there are some key take-home points that I hope you go home with. First, that the presented second trimester likelihood ratios can be used to adjust the maternal age-related risk for trisomy 21, however, shouldn't be used after prior aneuploidy screening. The vast majority of fetuses with a single sonographic marker for aneuploidy will have normal chromosomes. Remember that in the setting of prior low-risk aneuploidy screening results, a single sonographic marker for aneuploidy can be oftentimes considered a normal variant, and that some of these sonographic markers do actually, or rather may suggest anatomic abnormalities and do require additional follow-up.